Hello, and welcome. I'm Dr. Lewis Hassel, coming to you from the University of Oklahoma Health Sciences Center, and our program is called Surgical Pathology. It's a project of the Digital Anatomic Pathology Academy, which is a joint venture with the Digital Pathology Association and Path Presenter. I'm very pleased today to have quite an interesting case from our recent um, experience and wanted to share that with you. The patient is a 48-year-old woman who has been followed on our hepatology service and suspected of having cirrhosis. So that brought to my mind a question about what else could it be, particularly since obviously in this case it did not turn out to be cirrhosis. So let's take a look at that. Actually, she's 45. I take that back here. So radiographically, there are a number of things which can look like cirrhosis. And this would include things like very widespread neoplastic disease. It gives you a very nodular appearance. Widespread hepatic necrosis with some sort of regeneration can also have that same sort of multinodular pattern of appearance. There are a few other more uncommon syndromes in various age groups and settings that can also look a lot like this widespread cirrhosis. That can include things like Budd-Chiari syndrome, sarcoidosis, idiopathic portal hypertension can sometimes give you this, primary biliary cirrhosis, especially in its early phases, chronic portal vein thrombosis, nodular hyperplasia, Caroli's disease, and even some infectious disorders like schistosomiasis or fluke-related cholangiohepatitis. So these are not things to be totally glossed over, even though it may be that the most common scenario would be to interpret it as as cirrhosis, possibly secondary to a viral disorder and so forth. Now, of course, it can be quite disconcerting when you get that biopsy expecting to see hepatic fibrosis, nodularity, and so forth, and instead you just see this very seemingly monotonous array of tissue that does not look anywhere near similar to normal hepatic parenchyma. So here you can see kind of the low power. We have a very hemorrhagic background, and we have a sort of mixed pattern of red cells and pink tissue that looks very much like it could be some sort of neoplastic process. In addition, we have a little bit of inflammatory infiltrate here in this lesion that we'll take a look at as we go forward here. Coming into a little higher magnification here, we can see that the pinkish red material here looks to be red cells that are crowding in a variety of vascular patterns, vascular channels. We see some kind of blister cells, little bubbles in some of these cells, and a mixture of a few inflammatory cells in the background, but a lot of vacuolar changes and fairly low-grade appearing nuclei that appear to be forming this very vascularized backdrop. Now, there's not a lot of hyaline tissue here and so forth. As I've indicated, there is a little bit of inflammatory tissue in a few areas. Here's one such area. It actually looks like we have a little germinal center and some associated lymphocytes with a moderate amount of cytoplasm, and we can see some proliferation there. There are a few other larger vessels, but throughout this biopsy, although intended to be a sample of hepatic parenchyma, we see only tumor tissue. So clearly this is the lesion or the area that was considered to be the source of this process. So given that we have a fairly vascularized pattern, the first question was, could we verify that this is a vascular neoplasm? And so doing an immunohistochemical stain to evaluate that seemed like the next logical case. And then because some of these were somewhat epithelioid, we wondered about cytokeratin expression. Could this be hepatic in origin? But here we see a immunohistochemical stain for CD34, which shows that indeed we have a lot of very small lumina-like areas that are interspersed between these tumor cells. And some of the tumor cells themselves are expressing sort of a granular positivity to this marker as well. A similar pattern might be seen with CD31 or ERG. We didn't do those particular stains, but we did do cytokeratins, which, as we see here, is uniformly negative. So this is a CK7, which picks up a few residual biliary elements here in what's remaining of a portal tract, a few little remnants here. But by and large, the tumor is totally negative. And here we see the proliferation marker Ki67, which kind of underscores the fact that this is a low-grade neoplastic process. As we can see here, there's a pretty good labeling index. So this is helpful because certainly with an angiosarcoma, one would expect a much higher labeling rate, probably close to 40 or 50% with this particular marker. A couple of additional markers were done. Given the differential diagnosis that we were considering, well, let's see, here's a, oh, this is one of my controls. So we did a couple of additional markers to look at this lesion. And these were the protein product of certain fusion genes. So here is oops, let's get this on right in the right area here. So this is the fusion, this is the protein product for CAMTA1, CAMTA1, which is the most common fusion partner in this disorder. But in fact, this looks entirely negative. So we probably do not have a fusion partner gene with CAMTA1. However, in contrast, we also did the protein marker TFE3, and here you can see that this is nicely positive with this marker, giving us abundant granular cytoplasmic staining as well as pretty strong nuclear staining. So our leading diagnosis on this case was epithelioid hemangioendothelioma. Now, this is typically described as epithelioid cells amidst a myxohyaline stroma. Now, we don't have too much of a myxohyaline stroma in this case, but instead it's really quite a solid vascular, loose vascular stroma. And that is because, as we've indicated, there are two fusion genes that can be active here, and we are dealing with the case with the less frequently identified fusion partner, the TFE3 partner, and that has considerably less of this myxohyalin stroma. Of note, with this lesion, it tends to be multifocal and can often mimic metastatic disease due to other primary tumors. Typically, it's in the young adult age range, such as our patient, or middle age. And in terms of primary sites, most commonly it's found in the liver, but lung, bone, and occasionally spleen or other sites can be impacted by this lesion as well. Akin to our patient, many patients are essentially asymptomatic, and they may only be experiencing a little bit of weight loss or some abdominal discomfort. In more severe cases, less frequently, you might find hemoperitoneum or even portal hypertension. We've indicated that there are two common fusion genes that are involved. One is this one, WWTR1, linked to CAMTA1. And the other, which is the one present in our case, is YAP1 fused with TFE3. As we've shown you, it tends to be positive for vascular markers. Some keratins, most notably the very low molecular weight keratins, CAM5.2, CK818, can be positive, but the tumor cells will generally be negative for pan-site CK or CK7, as found in our case. In terms of the differential diagnostic considerations in this case, obviously angiosarcoma, clinically adenocarcinoma, and I suppose morphologically you would want to consider a signet ring type cell carcinoma, sclerotic hepatocellular carcinoma, epithelioid hemangioma, or anastomosing hemangiomas would be much less frequent and certainly would not have the elevated Ki67 that we've seen in our case. So our final sign-out diagnosis for this case is epithelioid hemangioendothelioma with a YAP1 TFE3 fusion, most likely the source of the neoplastic proliferation. So I hope you enjoyed that, and if you did, that you'll hit the like button and please subscribe so that you will catch new videos as we release them. And if you have comments, please don't hesitate to comment or reach out to me directly with questions or other observations. I'm always happy to get your feedback. So until next time, thanks so much for joining me.